In the remaining time, my task is to discuss something that we tend sometimes not think enough about, although we do. This is the patient's perspective of going through the treatments for chronic graft versus host disease. Just a quick reminder, there are many definitions of quality of life. It can be sometimes confusing, but I like this simple one by the National Cancer Institute. Basically, it says the overall enjoyment of life, sense of well-being, and ability to carry out activities of daily living. In our treatments, we are often, for a good reason, very much focused on survival goals and intensive therapies, and focusing on quality of life is connected with ensuring that life remains worth living. I'll talk later more about this, but it's quality of life are commonly assessed using validated multidimensional tools, so-called patient reported outcome measures. They include physical, emotional, social, and functional well-being assessment through the continuum of care. The patient-reported outcome measures, particularly those that measure quality of life, such as well-established SF-36, has been well documented in terms of predicting important outcomes like survival prior to allogeneic hematopoietic stem cell transplantation, and not only the full questionnaire, but on this study on the right, one single health status related question was highly predictive of survival. So it could be done simple and very, very relevant to outcome after transplantation. Our colleagues in the solid tumor oncology have been somewhat ahead of us in terms of generating evidence how patient-reported outcome measures are implemented into routine oncology practice and shown that they can improve patient quality of life, as on this study on the left, with improvements of FACT-G scores in randomized trials of cancer patients, and on the right side, in the control group, the intervention group, the intervention with monitoring quality of life and symptom outcomes resulted with better survival in patients with metastatic cancer, showing how these aspects can be target of intervention to improve major outcomes after cancer therapy. So in chronic GvHD, as we heard and we know, quality of life would be an important dimension of patient trajectory in this multisystemic chronic disease, and those aspects need to be and are to be more studied. The NIH consensus conferences have been mentioned by Dr. Moche already, and it's just a reminder of the trajectory that our field went through since 2005, expert-driven recommendations, 2014, evidence-based standards that paved the way to FDA approvals of new treatments, and then 2020 conference that is proposing focus on new paradigms and personalized therapy. These 19 papers have been extensively referenced in the scientific literature, just illustrating the impact they made on the science of bone marrow transplantation. So the 2005 consensus proposed for the first time organized set of response measures for chronic graft versus host disease, but at the same time proposed that patient's perspective should be included in a formal way. There is a series of patient-reported outcomes that have been put forward, particularly Lee symptom scale, functional assessments, HAP, FACT-BMT, and SF-36 quality of life scales. This is one of the first validations indicating that the NIH proposed patient-reported outcomes, Lee scale, SF-36, and others strongly correlated with the severe chronic graft versus host disease, reflecting the high relevance for being used in this patient population. This is a seminal publication, 2011, from the Chronic GvHD Consortium that shows that using and assessing quality of life through physical component summary scale on SF-36, highly and linearly correlated with the chronic GvHD severity from mild, moderate to severe, and as well put in perspective the quality of life of chronic GvHD patients in parallel with some of the most severe systemic diseases in medicine, like lupus, scleroderma, and others. Very compellingly demonstrating that patient-reported outcomes have a relevant role in assessment of patients with chronic GvHD. There's a long list of measures for patient-reported outcomes. It can get overwhelming and confusing. This is a meta-analysis review that was published in 2020 that in perfect way summarizes everything that has been done. This is a selected measures here that are mostly being used in chronic GvHD, some generic measures like SF-36 and HAP, cancer-specific like 5G, BMT-specific like 5-BMT. And then in this circle is some of the important chronic GvHD specific measures like Lee symptom scale that's been extensively and widely validated, as you can see, in the thousands of patients, and there's some others from the NIH consensus. And then particular of interest are these dimension-specific, organ-specific patient-reported outcomes that's been used and reported in a decent amount, particularly in clinical trials, for the oral assessments, ocular assessments like OSDI, and then skin itching assessments. So these are patient-reported outcomes that are relevant for specific organs and how patient perceives what's going on in that area with chronic GvHD. Next, in the Lee symptom scale, this has been the most frequently used patient-reported outcome measures in chronic GvHD, and it's a 30-item symptom scale with 7 subscales to calculate the summary score. There's a 7-day recall modification. They shortened the period from 1 month to 7 days of prior assessment. It takes only 2 minutes to complete, so it's patient self-report. A 5 to 6 point difference is being considered statistically meaningful. And the important things that there are standardized translations available today to at least 12 European languages. What's incredibly important for the barriers when you talk about application of patient self-report. This slide just summarizing the trials that led to approval of new agents for chronic GvHD, and as we know that all of them had a decent and nice overall response rates. But here, just want to emphasize and remind that what we saw before, that complete response rates remain still quite low, and just this is to emphasize here that we need more information on patients' perspectives and magnitude of improvements. What is really going on here in this situation where our measures don't capture exactly what we would like to reflect? So one example is this axatilimab study, 0.3 milligram arm, where it was observed, you see on far right, 26% skin chronic GvHD response rate. What's been it quite discrepancy from information that trial provided on a reduction in sclerotic chronic GvHD, skin tightening, even joints and fascia, showing that our response measures for speaking of skin, particularly in sclerosis, are not really reporting what we think it's actually going on and improvements in this patient. So to address this limitations that skin associated sclerosis measures are not capturing, being captured by current response outcomes. This is the provision of 55 items Lee symptom scale skin sclerosis. It's a new patient-reported measure that's been proposed recently and published in Blood, and needs to be further validated. But it's here to fill this gap and provide additional information on what we may be missing with the current assessment tools, including the least symptom scale needs. Could be in sclerotic disease, take some further refinements. The recent ASTCT panel proposed, because there's so many different patient-reported outcomes proposed for transplantation and cell therapy, trying to consolidate this field in the time as moving forward. And just to succinctly mention that this number one recommendation is to use PROMs and PRO-CKCIE measures for quality of life and symptom burden assessment after transplantation and cell therapy. I have to mention besides remarkable advantages and potential huge advantages of using these tools that still needs to be applied and tested and validated in transplant patients, particularly in chronic GvHD. And the last, what I circled, it's a recommendation that we should get more information about threshold measures and how to apply these tools to implement interventions that will ultimately improve patients' outcome, even survival, as our colleagues in solid tumor oncology demonstrated in randomized trials. The PROMIS tool offers two primary health inventories. One is the shorter 10-question PROMIS Global Health, assessing physical functioning, mental health, social health, and overall health perception. The longer is 29-question PROMIS, and they are well-developed, freely accessible tools like health measures that are publicly available without license fee or royalties to facilitate the implementation of this tool, and even translation from legacy tools for those who want to further use it in clinical trials or clinical care. The PRO-CKCIE, it's a counterpart of what's been used, toxicity scale. It's for toxicity in clinical trials, and it hasn't been tested in chronic GvHD. There are data in acute GvHD showing good potential for capturing symptoms in chronic GvHD patients, and as well outlining some limitations in applying in this patient population that relates to resources, patients, illness, and others. There's a very good evidence that particularly symptom scale that's really standing out, and for chronic GvHD population is highly recommended, even overriding that tools like PROMIS and others that have been recommended because there's so much good evidence. This is a study in the pivotal glutamic study that's showing that it correlates with responses. In REACH3 trial, least symptom scale, good correlation with responses as well, and as well as beta-mossadil. The little black box on the right in beta-mossadil trial is outlining the group of patients that didn't have NIH responses but still reported significant relevant improvement in the chronic GvHD symptoms, outlining that how important it is to use these symptom scales as complementary tools in clinical trials. And same with axatilimab trial, 60% patients reported clinically meaningful reduction in GvHD symptoms in about a 1 or 2 months interval. The patient perspective is increasingly important. To be said that what we as clinicians think, it's not exactly what patients always perceive as important. They're interested in how to improve stamina, memory, balance, fatigue, mood, nutrition. Not exactly what we always spend time talking to the clinic, or that we are even adequately trained to address. This study by Chronic GvHD Consortium just showed that patient-reported response had limited correlation with clinician reported, and it's complementary. So just making a data-driven point that we must include patient perspective in our clinical trials assessments. And this Lancet report by the European US group proposed that we should use patient community advisory boards to provide input on what's most important for them in patient care, This study outlined 5 aspects: empowerment, information, emotional support, dedicated care, financial support, and communication skills as an overarching need and deficiency that patients really care about. And this is just comparing the status of using PROs in clinical trials, where we are facing somewhat more success, while in routine care, I would say just the whole area is in quite an infancy. Only a minority of centers routinely use patient-reported outcomes in patient care, mostly symptom scale, and the evidence that targeting those outcomes to prove survival and quality of life, formal studies need to be done. They haven't been done yet. And this is a future direction, so we need to validate PROs, particularly proposed PROMs and CTCAE PRO, that data need to be generated. We need to incorporate PROMs in clinical care. Those algorithms don't exist. We need to focus in some less studied patient self-report areas that reflect occupational therapy aspects and lifestyle medicine pillars, and then integrate objective and subjective measures into new holistic assessment tools for GvHD as part of the formal responses, where we think that currently used response measures for clinical trials actually could benefit from adding more upfront and formally patient's perspective on symptoms and improvement.
One question which I thought was very important from the audience: would you rely on quality of life and the other PROs in treatment decisions when it comes to switching drugs, for instance, or lines in chronic GvHD?
It's of course a great question, while formal algorithms don't exist, and we should still generate that evidence, what I personally think would be immensely helpful, as has been done in oncology trials, to help our assessments, because right now, as we know, it's quite challenging decided, how to prioritize sequence or taper the drugs. What I would say, one, we need clinical studies to generate formal evidence, and two, patient-reported outcomes have been not used enough in routine clinical practice. There's a not good enough strong reason for something like SLEE scale not to be used, and I would encourage practitioners to gather that information and use as an information tool in the totality of when we need to decide, which drug to introduce next. We realized, that there's lots of things that come into this equation, and definitely patient perspective, in my opinion, should be taken in consideration.
And I got it right. The SLEE scale has 30 questions, correct?
2 minutes.
Okay. One last question before we move to the post-symposium questions. On the other hand, if you have, based on the NIH criteria, little or no improvement, stable situation, but the patient is declaring a clear improvement in his quality of life and PROs, how would you consider this?
That's a not uncommon clinical scenario where we need to decide how to proceed in a stable disease. In protocol scenario, some protocols accommodate for that case scenario to continue treatment even if patient fails the primary outcome. And second, I think that again it's a clinical judgment, but if patient reports improvement, that's exactly a situation where we are definitely tempted and almost compelled to continue therapy if there is such perception of benefit on the patient side.